take paper and you open the, just share the hangout. Call him and वापस आपको and put the PowerPoint. Okay, thank you. Thank you. Mute both their microphones, please. Hand it over to Vikas.
Okay.
Apologize for the technical problem.
Hey, no problem. We can start from wherever we left over.
Yes.
That's fine. As we were talking, intensive insulin therapy versus transplant. So what are the advantages of transplant over intensive insulin therapy? Intensive insulin therapy does not achieve a perfect glucose control, whereas transplant is as good as it's basically having a new pancreas. So it's new life, it's perfect glucose control. Intensive insulin therapy increases the risk of severe hypoglycemia many times. The severe hypo or hyperglycemia is completely eliminated in this transplanted pancreas because it's as good as you being normal, non-diabetic. Increases the burden of day-to-day diabetes management. The intensive insulin therapy does increase the burden of day-to-day diabetes management. Patients need to get their, they need to check their, monitor their blood glucose. They need to give injections at particular times. It eliminates the needs. Transplant will eliminate the need for insulin injections, blood glucose monitoring, and dietary restrictions. All these are gone. So it's as if you've gotten a new life. Next slide, please. So there are several advantages and disadvantages of pancreas transplant as well. It's not without disadvantages. As I said, we talked about the advantages. Some of the secondary complications like partly nephropathy, for sure, neuropathy, can all get reversed after prolonged pancreas, pancreas transplantation and long term. The quality of life is definitely good with a pancreas transplant, and ultimately we achieve the goal of euglycemia, which is what we are looking at in a diabetic patient. The disadvantages are, of course, an operation. So whenever there is an operation, the complications of surgery come along with it. Then patients need to be on immunosuppression, which is a toxic medication, which they need to be on lifelong. And the cost of these immunosuppressive medications, the cost of the operation itself is definitely higher when you put everything put together versus doing continued insulin therapy. Next slide, please. So there are various types of pancreas transplants, which we know of. I'll be using these terms a lot in my lecture today. What is an SPK is a simultaneous pancreas and kidney transplant, or pancreas PAK means pancreas after kidney transplant. As you can see in the figure on the left side, you see the pancreas, which is attached to the iliac veins and the arteries on the right side, and kidneys usually on the left side. Or it could be on the right side of the figure, what we call as pancreas transplant alone. So people with brittle diabetes can have pancreas transplant alone. And again, there are various drainage methods, which we can talk about a little bit more in detail later. So next slide, please. Again, the more disadvantages, when we're talking more about the disadvantages for pancreas or the islet transplants, the most important thing are the surgical complications which happen, the immunosuppressive medications, which is a major disadvantage because these immunosuppressive medications have a lot of complications. They're not without complications, and the cost as well. So we need to balance the advantages and disadvantages while we are offering patients pancreas or an islet cell transplant. Next slide, please. So this is what we looked at it was actually looked at in University of Minnesota. This is a photoelectron microscope of a patient's calf, like a normal patient's calf muscles. Their nerves are in the green, and yellow, they represent the nerves. Basement membrane is represented by red, and the epidermis and the vessels are represented by the bluish hue in this electron micrograph. Let's look at the next picture. In a diabetic calf, as you see, the nerves are all degenerated and they're dead. So neuropathy, part of it, very important, right? So that causes all the complications. And as you see, in a diabetic calf, the nerves are almost gone. Let's look at the next slide. So a patient who is 33 months after transplant, you can see that there is regeneration of the nerves in the calf, right? After pancreas transplant, after 33 months, this is the photoelectron micrograph, which shows that there is regeneration of nerves, which is started. So there is reversal of some of the organ complications caused by diabetes with the help of transplant. Next slide, please. Even if you look at the kidneys, on the left side, you can see pre-transplant, there is glomerulosclerosis, which is one of the diabetic glomerulosclerosis, which ultimately causes diabetic nephropathy. And about 10 years post-transplant, you can see the same patient's kidneys. There is a restoration of normal glomerular anatomy on the right side, which you can see the renal biopsy obtained before and after pancreas transplant. So definitely the impact of pancreas transplant on native kidney is something which is very significant, and it will help these patients preventing from going into end-stage renal disease. Next slide, please. So the outcomes have also been significantly improved in the last decade. Over the past 10 to 15 years in pancreas transplant. The pancreas transplant was started mostly in the 1970s and 80s. And when we looked at the outcomes from the 70s to 80s to what it is now in the 2000s to 2010s, it's definitely improved in the last decade. If we look at the next slide, please. So you can see the 1-year patient survival in 88 and 89 was close to 90%, but now it's as high as 98%. So 1-year patient survival is definitely improved over the past several decades. Again, SPK means simultaneous pancreas kidney, PAK means pancreas after kidney transplants, and PTA means pancreas transplants alone. Let's look at the next slide. This graph also shows pancreas graft function. So in the 80s, because we did not have good immunosuppressive medications, the pancreas transplant graft survival was very low, close to like just 50%. But now it's gone up. At the end of 1 year, the functional grafts is as close to 80%. So that's a major improvement in graft survival and graft function in pancreas transplant, which is mostly attributed to immunosuppression, the newer immunosuppressive medications which we've got. Let's look at the next slide, please. Again, the graft rejection and loss, which were as high as up to 40%, have now come down. As you can see, simultaneous pancreas kidney transplants have a better outcome than pancreas transplant alone. We'll talk about it a little bit later. Next slide, please. So survival after pancreas transplant versus remaining on waiting list. So what if these patients mostly need to have deceased donor pancreas transplants, right? So they're on the waiting list for a pretty long period of time. So we looked at, there are several studies which looked at what if you get a pancreas transplant versus person who is not getting a pancreas transplant? How will pancreas transplant help in improvement of your survival? Next slide, please. As you can see in this analysis, the bottom part where you see the simultaneous pancreas kidney transplants, the last graph, it does show that there is increase in favor transplantation, right? So the survival is much better with transplantation with SPK. But with PAK, that is pancreas after kidney, it's kind of favoring towards conventional therapy, but kind of more going towards the transplantation. There are only very few studies which say, or at least pancreas transplant alone is equivalent or okay with the conventional therapy. Next slide, please. So the pancreas transplant in the contemporary cases, what is the outcome? Let's look at it. Next slide, please. you've seen that now the months post-transplant, the patient survival is more than 90% mostly, and with the pancreas transplant alone too, it's close to 98%. So the patient survival has definitely improved when compared to what it was in the 70s. Next slide, please. The pancreas graft function is also increased quite a bit. It's definitely with the SPK, as you can see here, it's up to 85% at the end of 36 months. It's a pretty good survival for simultaneous pancreas kidney transplants. From what it was in the 70s, it was just 40 to 60%. So it's doubled definitely at the end of 3 years. Next slide, please. Again, the graft loss due to rejection have definitely improved in the first 12 months to 18 months, as you can see. It's just in the first year, it's less than 10% almost. Like the pancreas transplant kind of reaches up to 10, but everything else, there is only 2% pancreas graft loss in simultaneous pancreas kidney transplants now. So that's a major improvement in patients, which also means that we are definitely, and most of it again is attributed to increasing immunosuppression and neuroimmunosuppressive medications. Next slide, please. So improving results of pancreas transplant. Well, let's look at what were the factors. Next slide, please. Which caused this pancreas transplant to get better. So causes of graft loss, why did the grafts were lost? Were most of it, up to 20%, as you can see, is because of immunological failure, which means there is rejection. And that's something which we're kind of working on, neuroimmunosuppressive medications. And that's the most common cause for failure of the graft to take. And then the next most common cause is technical failure. So pancreas transplant is a very labor intensive, or it is a very surgically demanding procedure. Not everybody can do this. It needs the expertise of very good surgeons to do this. And 9% of the patients die with a functional graft, which is another way of looking at the graft loss. And primary non-function is very low. It's just in like 0.7% of patients. So next slide, please. So the causes of graft loss by transplant category. So those patients who die with a functioning graft are the most common cause for pancreas transplant. Like in simultaneous pancreas kidney transplants, most of the patients die with functioning grafts, which is a good thing. And then the rate of immunologic rejections is lowest in simultaneous pancreas kidney transplant. And the technical issues which lead to graft loss are pretty much close to like 19 to 20% in all the three categories of transplant, whether you do simultaneous or pancreas after kidney or pancreas transplant alone. Next slide, please. So the most important, again, we looked at were the immunological causes, right, which caused the pancreas transplant to go not work, or non-failure of the pancreas transplantation. The most important reason for that is chronic rejection, which is defined clinically as loss of function of the graft that was initially working, usually about 3 months after transplant. Let's go to the next slide, please. You see, this is kind of how we look at when there is chronic rejection of the graft, wherein you see those big pink dots on the upper part of the slide. They are actually the arteries, which are all being infiltrated, and ultimately the blood supply to the graft is lost because these tiny arterioles in the arteries are infiltrated, and they by the immunological cells, and ultimately fibrosis and loss of graft. And this is how chronic rejection looks under the microscope. Next slide, please. So we looked at multivariate analysis of risk factors for why does this chronic rejection happens. For patients who have acute rejection, that is rejection which happens kind of in the first 2 to 3 months after the transplantation is called as an acute rejection. And if you have multiple episodes of acute rejection, that will ultimately lead to chronic rejection as well. Of course, patients with simultaneous pancreas kidney transplants, the kidney actually acts as a protective barrier because kidney also has a lot of immunological function. So simultaneous pancreas kidney transplant from the same patient means that the new functioning kidney will protect the pancreas from getting damaged. So, and other infections like CMV infection or retransplantation for patients, a number of mismatches, which we look at in the kidney transplant, these all are factors which affect the increasing the chances of the patient going chronic rejection. Next slide, please. There could be technical failures too, which is the second most common cause why a pancreas transplant doesn't work. Next slide. So the incidence of technical failure has definitely improved from 30% to close to less than 10%. And this is, again, basically attributed to surgeons being more comfortable doing the transplants, more people getting more familiar with the technique, and as year goes by, and our technical failure rates are definitely coming down. Next slide, please. So the cause of a technical failure could be, the most important is thrombosis. That means the blood vessels, which we anastomose to the going into the new pancreas, they can get blocked. And that's the most important cause why a person can lose their graft. Other thing, the next most common is infections. It could be viral, like CMV, because these patients are on immunosuppressive medications. Infections are the next most common cause. And then pancreatitis can happen in these graft patients. And then there could be leaking, bleeding, and other causes for graft loss. Next slide, please. Next slide, please.
Sir. Hello, sir.
So just want to start with the same slide. Okay. The voice in it. ಇದು ಕೇಳಮ್ಮ ಇದು ಅಲ್ಲಿದ್ಯಾ ಇಲ್ಲ ಇಲ್ಲಿಗೆ ಇಲ್ಲಿ ಮಾಡ್ತೀಯ One minute.
Hello.
Because
Oh, okay. So I didn't have much left. But, Haley, sir.
Okay.
So just
Okay, it is done. Just 1 minute.
Okay. All right.
Because you can't see this. So we can't call by WhatsApp. Oh, WhatsApp, madam. Just ask him to hold. One second. We'll start very left. He's not able to see the board. Speaking, 1 second. You just call him in.
Hello? Yeah, yeah. So as these were the causes, as we said, about the pancreas graft loss. Can we get the next slide, please? So some of the reasons why would the graft would get lost would be the graft loss. One of the most, we looked at what were all the factors. And one of the most important. Is it okay for me to continue to talk? Okay. So the multivariate analysis of risk factors for this graft failure, donor BMI was the only thing which was statistically significant. That is, patients who were fat, if we take pancreases from patients who were obese, then the chances of the graft being bad and graft failure are pretty high, and that was very significant. Next slide, please. And also, as you can see, if the BMI is higher, that is more than 30, which is seen on the yellow lines on the graft, whether the patient died from trauma or whether the patient died from a coronary vascular disease, the rates of rejection of these patients is much higher. So we need to take graft from somebody who is not obese. Obese patients have bad pancreas. Next slide, please. And also preservation time was another thing which showed that there was a high risk factor for the transplanted pancreas not to work well. Next slide, please. It does show that patients who have higher preservation times beyond 20 hours, they have bad outcomes. So we need to kind of look at when we take the pancreas out of the donor, it needs to go into the recipient within 20 hours, ideally within 6 to 8 hours, but at least within 20 hours. Next slide, please. And preservation time also caused increased leaks and surgical complications. The longer the preservation time, the more the surgical complications, mostly the leaks were seen. Next slide, please. So you can see this is a pancreas graft, which is thrombosed, and there is pancreatitis with yellow fat, that is necrosis of the graft. And this is a complication for people who have had prolonged preservation times. Next slide. As you can see here, the graft is completely thrombosed, and this is the pancreas graft. That's the body of the graft, and you can see it's all bruised, like as if it's been beaten, and that means that there is all the blood supply is all gone. It's all thrombosed, and the graft has failed. Next slide, please. So let's look at